Welcome, everyone. My name is Corinne, and I will be your moderator this evening. I'm excited to welcome Dr. Misci, a leading clinician and senior faculty member at the postgraduate prosthodontic program at Boston University, as our speaker tonight. She will be decoding and simplifying the process of evaluating and selecting the most appropriate treatment modality for the patient. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it into the box labeled Have a Question on your console. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Dr. Misci, welcome and thank you for being with us tonight. I will pass it on over to you now.
Good afternoon, everybody, and thank you for attending today's presentation. Thank you, Henry Schein, for the kind invitation and for the smooth, seamless organization. You did a great job. Thank you. So today we will talk a little bit about treatment options for the edentulous patients. We will talk about Airway and how that affects us as restorative dentists. First, I would like to have a disclaimer. Most of the pictures in this presentation are our own patients that we treated with our residents at Boston University. However, there are some photographs in the presentation that are simply for the purposes of discussing concepts for visualization of those concepts. So I have taken those from online sources and I have provided the links of those sources at the bottom of each slide. What would we talk about today? So we will talk about briefly the restorative options for the edentulous arches. We will talk about evaluation and treatment planning. We will talk about the impact of the airway on our treatment options, and we will draw some conclusions. Let's start with the restorative options. We all know we have fixed and removable options for the edentulous jaws. The removable range from conventional complete denture to stud over dentures to bar over dentures, where the fixed options are actually more variety of combination of things. So we can have either a restoration that only restores the white portion of the tooth, the coronal structure, or we can have one that restores both the coronal structure and the missing soft and hard tissues. We can have a prosthesis that goes directly to implant level and is retained directly to the implants, or we can have prostheses that are attached to abutments, either prefabricated, custom abutments, multi-unit abutments. And the prosthesis can be retained via screws or cemented. All of these options have advantages and disadvantages. And courtesy of two of our former residents, Dr. Shambis and Dr. Hashim, they did a little overview of the different materials and the different options and the potential complications, advantages, difficulties. Nowadays, the streamline is the monolithic zirconium. It is something that is done by most labs. It's a digitalized material, so it's easy to plan, easy to modify digitally. Then we have a copy that we can duplicate if needed. So the zirconia has become a mainstream nowadays. Of course, it has disadvantages as well, and hopefully new materials are coming and improving those. But we will concentrate today more on the evaluation and treatment planning. Just like with everything else in life, it helps to have a goal, to have a clear goal. The clearer the goal, the more defined the path is. And in our restorative treatments, the goal is our restoration. The starting point is the existing condition. And then that bridge is the prototype for me, because that is that uncertain part that we have to figure out and put together the pieces of the puzzle. Once we have that prototype, we can duplicate it into our final restoration. So once I have the prototype, I'm pretty confident that after that, the treatment is easy. That's why I'm going to spend a little more time today to talk about the prototype. So what is a prototype? A prototype is a preliminary model of something from which other forms are developed. And we can be very creative with that. We can have existing hopeless teeth as a prototype. We can have a mock-up, either composite, wax, or any other material we would like to implement. We can have removable immediate complete dentures as a prototype. We can have a special appliance fabricated. We can have a provisional bridge over teeth that are to be lost as a prototype. It's basically something that would help us envision the future restoration and help us get there. For example, existing hopeless teeth. Through the old-fashioned way of taking a quick alginate impression and just marking on the model which tooth needs to be shorter, which needs to be longer, how to change the midline, how to change the angulation of the teeth. So all of that can be outlined on the model and then transferred into a digital wax or physical wax up, or simply the mouth can be scanned and these modifications can be done virtually. So there's a lot of options how to do it, but the concept is let's figure out what we want to achieve first, outline it, and then whichever option works best for us, we can implement. We can have a prototype also through a mock-up, a wax mock-up. For this patient, Edentulous maxilla, we created a record base with wax teeth, which we tried in the patient's mouth, did some modifications, and this is our prototype for planning the rest of the treatment. A mock-up can also be a direct composite in clinic chair. Just add a little bit of composite on those hopeless teeth to decide where we want that incisal edge to end, what is the angulation of the midline, where we want the gingival margins to be, just roughly, very quickly, chair side, and then we can transfer this to the rest of the planning. Also, a prototype could be a specially fabricated appliance. Like in this case, we use the patient's existing dentures, maxillary denture, which needed to be modified just slightly. Some teeth needed to be altered. We did that virtually, and then we printed the prototype and tried it in the patient. A prototype can also be a provisional bridge. For example, for this patient, we have some hopeless roots, implants that are well integrated and in good condition. The patient has no display of clinical crowns, so we made that bridge, and now we have a prototype for the planning of the implants. So those prototype steps are very important for any kind of treatment, but we will go a little bit more in detail about the full arches and how we implement those prototypes in our treatments. Now, I try to keep things simple, so I have narrowed it down to 3 important steps for the full arch restorations. And I like to have the 3 check marks. The first one is determine our tooth setup. So what is going to be our future tooth position? So this is the complete denture concept. We need to imagine that we have no teeth and we're going to put the teeth in the best possible position. And what would that position be? So that is the first step. How do we determine this position of the teeth? Well, we go through 4 steps. We have to determine the maxillary incisal edge position, the mandibular incisal edge position, the vertical dimension, and we have to find the repeatable occlusive position to which we want to restore the patient. The second step is to determine if we need a prosthetic flange or not. This is a big step because for some patients, lack of prosthetic flange is unacceptable. If that is the case, we have to go with a complete denture or overdenture. Sometimes we can get away with just bringing that margin, prosthetic margin, deeper and trying to create bulk at that level. So we give more support to the lips. But it's not for every case. It depends on how much is lost already. So the need for prosthetic flange is my second step after determining the tooth position. And we can see in that case, we started as a complete denture. We had the tooth setup. The patient really liked the tooth setup. And from that tooth setup, we scanned and fabricated 2 prototypes, one with flange and one without the flange, which is our protocol now. And from trying those 2 prototypes, it's not very clear on the pictures because the prototype we printed from a clear material. Now we do from tooth color material. So for pictures, a little bit difficult to see, but patient rejected the flangeless prototype simply for the lack of lip and cheek support that she had. So she just didn't accept that option. So we had to go with the denture option with removable. So the third step is to determine the position of the prosthetic margin. We can have a restoration that restores only the coronal portion of the teeth, or restoration that restores the coronal and the tissue part that has been lost. However, for those prostheses, we need to determine where that margin would lie. That margin depends on what is visible. So we have to determine the lip mobility. As you can see in this case, when the patient is just smiling regularly in normal function, we have beautiful reveal of the prosthesis. However, when the patient is laughing and really those lips are being pulled up and back, we can see the prosthetic margin. So going through that evaluation and determining how deep to bury that margin is extremely important. So later we don't have this issue. So again, the 3 steps for me, the 3 check marks I want to have are the tooth setup, the prosthetic flange, and the position of the prosthetic margin. So let's look at some cases and we'll go over that for every case. This patient has 4 maxillary implants in good condition but never restored, and has 4 remaining roots that need to be extracted. So maxillary incisal edge. Maxillary incisal edge position will determine the same way we will determine that with complete dentures. So we will make a record base occlusal rim and we'll adjust the occlusal rim to the level that we want our future maxillary incisal edges to end. Mandibular incisal edge position, we can evaluate clinically and we can see that they're actually in pretty good position, except for number 21 and 22, which is supraerupted. Vertical dimension, we will determine when we have our occlusal rim, the wax rim, and we will adjust it to the desired vertical dimension. And the occlusal position, our record, we will record at that point as well. And we have some parameters that we follow to determine our maxillary incisal edge position, video, then we take a phase bow and our occlusal record. Based on those records, this is a case before digital technology. We would make a silicone putty, which will imprint that wax rim. So we have now the incisal edge position. Then we will remove the record base with the wax rim and we'll ask the lab to fabricate provisional crowns to that level on that cast, directly over the remaining roots and implants. So now we have the provisional bridge on the upper, and that is at the video that we want. The incisal edges are where we want them, and it is in a stable occlusal position. This gives us a lot of information now. That is our prototype. Now, let's look at the need for prosthetic flange, our second step. As we can see from all the patient pictures, he doesn't need any additional lip support, so we don't need prosthetic flange, which means we can go forward with implant fixed restorations. Our third step, the position of the prosthetic margin. So in this case, we actually don't need to restore any soft and hard tissues. We will go only with the white material, restoring only the crown portion of the teeth. Because of the position of his lip, it's not needed. However, something important we notice here is that his gingival margins with these temporary crowns are quite uneven. And this is because of the root levels and CEJ, from whatever's left from it, is at that level. So if we're to just extract those roots and place implants to bone level, we'll most probably end up with this gingival margin for our future implant restorations. He's a low smile line, so he wouldn't show it. However, it's a good thing to evaluate before we place the implants. In this case, to even out those margins, we would simply place the different depth of those implants. For example, if we decide that our number 8 is in good position for the margin, or it can be brought apically maybe another millimeter, we will plan our implant to be about 4 millimeters from that margin. However, number 9, we will place a little bit deeper, about 5 millimeter, and the canine would go about 3 millimeter because it looks in good position, the same with the other canine. And we can plan for a little bit of graft in the lateral region, and of course some implants posteriorly. So basically, by having this prototype, it gives us a lot of information for our implant placement. So again, prototype is very important to have the next steps outlined, determined, so we can have a predictable final result. And for this case, the final restoration was placed, and we have a picture of it. We have the existing condition, the starting point, and then our prototype was the temporaries, which gave us all the information so we can get it from prototype to final restoration with proper planning. So for the next case, again, the first step is the tooth setup, maxillary incisal ledge position. For this case, we did a chair side with some composite. And this is a case that one of our prosthodontic resident, Dr. Duang Suvan, is working right now, and I'm supervising her case. So we're really enjoying this technology we're using with her. So we did a quick mock-up clinically and determine our incisal edge position and the angulation of the midline. In terms of mandibular incisal edge position, we can see that our canines are in pretty good position vertically. However, the centrals and the laterals incisal edge can be increased. And we determined this without retractors. I don't have that picture here right now, but it's about the reveal of the lower incisal edge position when the lips are in rest. And we want to see about 2.5 millimeters or so. So for the canines here, we say that there is a wear, but there's also supraeruption. So that vertical position is where we want to stay. Patient will have most probably crowns on those teeth, but we can maintain that vertical position for the canines and just increase the incisal edge for the laterals and the centrals. Now, vertical dimensions. So we added composite on the lingual of those incisors to hold the vertical dimension that we wanted to achieve. And in terms of finding that repeatable occlusal position, we used that piece of composite as a jig, so she would constantly close in that position. And once we determined that position, we could record it. So now that we have those composite buildups, we evaluate her smile as well. She's very hesitant to smile as she's trying to not reveal the existing teeth. So it was very difficult to determine what is her actual exaggerated smile. But at this point, our goal is to fabricate for her an immediate denture. She's in pain. She needs those teeth extracted as soon as possible. So at this point, our final restoration is actually the immediate denture for this step of the plan. Once we have that, our goal will change to the final restoration, whether she goes with just complete dentures, overdentures, fixed restorations. So that will be the second step of the treatment. So what we did for this case is after we have the intraoral mock-up with the composite, we did intraoral scans, upper and lower. So now we have the incisal edge position for our immediate denture. Our Byte registration is, as I mentioned, a composite jig on the lingual, which gives us a stop. So this is the vertical dimension and the occlusal record that we wanted to make. So we scan that occlusal position. We also took impressions, and the reason for that was because we scored them to the borders, desired borders of our immediate dentures that are based on some landmarks we know about. So based on that, our borders are more predictable for the restoration versus if they're just based on the scan, in which case most of the time we have overextension of the denture. So these are scans now, lab scans of the models. So we did intraoral scans at the chair side and then took impressions. The impressions we scored and scanned as well. Then we merged everything and we developed our posterior plane of occlusion based on Pound's triangle, which says that the vertical level of the posterior teeth at the mandible should lie on a line from the canine to half to 2/3 of the retromolar pad. And as I said, our canines were in good position, so we can use that as a reference. And then buccal lingual, the position should be of the teeth is such that if we draw a line from the mesial of the canine to the buccal and lingual of that retromolar pad, that triangle that is formed, the lingual cusps of the premolars and the molars should lie within that triangle. So based on that, now we can develop our maxillary plane of occlusion. We already had the incisal latch position for the maxillary teeth. As I said, we knew how much we wanted to build the mandibular incisal latch. We had video, we had CR, we developed the posterior plane of occlusion based on Pound's triangle. And now we can fabricate, digitally design and fabricate immediate denture for this case. So this is all part of the planning. The tooth setup, and these are the dentures. So basically, in 2 clinical appointments, we are able to give the patient immediate dentures. The first appointment is the intraoral mock-up, scan intraoral, and then the impressions. The second appointment is the extractions and delivery of the immediate dentures. We haven't seen the patient for the delivery of the dentures, so she hasn't had the extractions and the delivery yet. But hopefully in the next presentation we will have that. Now for that patient, the prosthetic flange, the second step. Do we need a prosthetic flange for her? Considering she has good lip support, we don't need a prosthetic flange. So potentially she can go to fixed implant restoration. Now in terms of position of the prosthetic margin, this is very hard to determine at this point because the patient is not properly using her lips at this time due to her habitual trying to not reveal and protect the broken down teeth. However, once she has the immediate dentures, most of the time things change. The patient is confident and all of a sudden is smiling big. So at that point, we will be able to see how far that lips retracts during her most exaggerated smile and determine how far from that position we need to go deeper to hide that margin for a future restoration. So as I said, for that future fixed restoration, that will be the next step of our treatment planning. And that will be done after our immediate denture. So the final restoration for this stage is the immediate denture, the existing condition we had, and then the prototype is that mock-up. For the next step of the treatment, our final restoration will be the actual restoration, depending on which way she wants to go, and we will go from there. Now, the same step for another case. We have Edentulous maxilla, determining the maxillary incisal latch position the same way as in the first case. We have to have a wax rim, we adjust it, and that will give us the incisal edge for the maxilla. For the mandible, actually the incisal edge is pretty good position, so we will not plan to alter that. Again, a silicone putty index. Based on that, we develop that wax up on the occlusal rim, and we try it in the mouth. So this is our prototype, and this is the step for the tooth setup. Now, for prosthetic flange, need one or not. For this case, we don't need one. This is really a patient's decision because a lot of those edentulous maxillas, there's already some loss that has occurred, and the patient needs to determine if they really need that flange or not. Some patients are okay with a little flatter profile, and some patients are absolutely not. That's why we go through this step where we give them the option to try one with a flange, one without the flange, and the patient can make a decision. So for this case, she decided she doesn't want a prosthetic flange, doesn't need one, so she will go with the fixed implant restoration as a final restoration. And whether or not we will restore with pink or no pink, for this case, we decided to go with no pink as she had a lot of bone vertically, so there was just no justification to remove even more bone than already she had lost at this point, that she's not a high smile line. However, one important part of the evaluation is if you look here carefully on the right side, you can see that she's showing a little bit of pink, which means that the implants on these two teeth will have to be placed deeper. So we hide that prosthetic margin afterwards, and it's even with the other side. So for this case, the final restoration was the temporary. This is just an immediate temporary placed immediately after the surgery, guided surgery case. And you can still see how short are those teeth. However, the implants are placed to the proper depth. So once those implants are healed, we can push the tissue and modify and have something that looks more like the prototype we created. So basically, the function of the prototype was to give us the proper implant position and specifically the depth of the implant so we can have those restorations in the end. Now, for another case, the tooth setup, again, maxillary incisal latch position. This is the patient that presented with existing dentures. After careful evaluation, the position of the teeth was very acceptable. There were a couple of teeth that needed a slight modification. So what we did was we scanned that denture. I'm missing a slide here. However, it's probably in the next slide. So anyways, the incisal latch position is very acceptable, needed slight modification. Now, in terms of mandibular incisal latch position, that was very acceptable as well. Vertical dimension was good with the existing dentures, and he had a stable occlusion with the existing dentures. So in terms of prosthetic flange, what we did is we scanned the existing denture, and we did digitally modification of the tooth position of some of the teeth that we felt the position could be improved. And from that, we printed two prototypes, one with a flange and one without a flange. Now the patient tries both. And patient approved a no flange prototype. So we can go ahead with fixed restoration. So no need for a flange. It's my second check mark. Now the position of the prosthetic margin. We know we're not going to have a flange. However, we put the prototype in the patient's mouth that has a flange. And now we look how far that lip goes in function. And we can clearly see here that we see all the papillas and some of the gingival margins, which means that we will need to use pink porcelain, however, or pink composite with different materials. However, how far we need to go now for our implant position is very important because we don't want our prosthetic margin to be visible when the patient is in function. So what we do is we draw a line here to that lip position, and we will plan our margin, prosthetic margin, to be 2 millimeters more apical than this line to that most exaggerated, most retracted lip position. And then our implants we place even further from there. So we basically have to calculate the exact numbers based on the components we will use. And I just want to mention that this is a case that I did with Dr. Ali Abdallah when he was a resident, and he is now one of our leading faculty at the department and a superstar. So very excited to work with him on this case. So basically the technique was, we place that prototype that has a flange. We draw the line. We determine that we will use pink. And now we will place our prosthetic margin based on that line by making a little divot above each of those teeth and put some radio-opaque material in that. So we will scan the patient with that prototype. So knowing that these gutta-percha markers are as far as the lip will go. The patient is scanned with that. So this is what we see now on the scan. So we see all of those gutta-percha points above each tooth. We place them above each tooth because at this point we don't know where we will position the implants based on bone availability. We want to spread them out. But again, we don't know exactly where they will go. So just to be safe, we put them on every tooth. So we have all that information when we plan the implant position. And we can see here the white marks. This is our most retracted by the natural function of the muscles lip position. Now, we said we want to hide the margin above that. So we will count about 2 millimeters from that mark is where our prosthetic margin will be. And then from there, we will go another about 3 millimeters to allow for soft tissue and the multi-unit abutment to go to the implant level. So basically from that white dot, we're planning about 5 millimeters to the implant platform. If the implants are positioned in such a way that we will use straight multi-unit abutments. If we're going to use angled multi-unit abutments, we have to calculate for that as well because they might have wider collars and we have to place the implants deeper. But this is all the information we need in order to hide that prosthetic margin. And this is the surgery. So now the patient has the temporary prosthesis. As I said, the temporary is our next step as long as everything is good with it and it is based on the proper planning. We duplicate just a cutback and we can have the future restoration made, which is very, very similar to the temporary restoration. So basically the final restoration, the existing condition, the prototype for this patient are as follows. The existing denture, which was slightly modified, and those two prototypes made based on which we had the planning for the implant position, specifically the implant depth, height, that prosthetic margin, have the proper tooth setup, and obviously the need or not for flange was determined at that appointment as well. So these are the 3 check marks again that we go for every case: the tooth setup, prosthetic flange, and position of the prosthetic margin. Now we're going to concentrate a little bit on the Airway. Okay, so it is becoming more and more important to look at this part of our patients and understanding more and more the impacts of obstruction. So I will spend a good amount of time to talk about that right now. What is a sleep apnea? It's a sleep disorder, something that happens during sleep and is characterized by episode of apnea, no breathing, or hypopnea, where it's incomplete obstruction. So some air is going in, but not all the way. Now, what does that mean in simple terms? Basically, the patient cannot sleep and breathe at the same time. Now, we have different kinds of sleep apnea. One is central sleep apnea, which is basically the brain is not sending impulses to the diaphragm, to the muscles to to start breathing. So there is no respiratory effort. Basically, the patient is not trying to breathe, just stops breathing because the brain is not telling the patient to breathe. That is, both of those are medical conditions. They are diagnosed, they are managed, treated by the medical team, but we can contribute to the second one. So the obstructive sleep apnea is different than the central sleep apnea in a way that the brain is sending impulses, breathe, but the patient is trying. There is a respiratory effort, the lungs are moving, but there is obstruction in the pharynx so that no air is going through. Why is it important? Obviously, breathing is important, but in the later years, we are understanding how much sleep is important. The sleep benefits are so many. I'm not going to read them all, but basically, a good night's sleep affects every system of our body, of our development, of our mental well-being, health well-being, and more and more we are recognizing how the lack of sleep affects every part, every system of our body. Now, there is a very popular video on YouTube. You can look it up. It's from some research from Boston. So it's basically showing how when the brain is not very active during sleep, so the impulses, the slowing down, how there is a pumping of the cerebrospinal fluid through it and cleaning up all the buildups. So that's very important. It's like cleaning up our brain, and it happens during sleep where the nerve impulses are low. So our brain is quiet and is allowing for that pumping of fluid to go through and clean it up. So what are the main consequences when we don't have good breathing while we sleep? Obviously, our oxygen level goes down, which makes every system of our body suffer. But the other part is the cortical arousal. So basically, our brain keeps waking up constantly because of the lack of oxygen. Wakes us up, we start breathing again. Fall asleep, we stop breathing. Oxygen goes down, brain wakes up, start breathing again. So that causes that sleep fragmentation. So our brain cannot go to those deeper stages of sleep that are so important and restorative. And as a result of all this, our body gets into that stage of fight and fright. The sympathetic activity goes up, our blood pressure, heart rate fluctuates. So it keeps us in a constant level of stress. So none of this is healthy. We're not getting enough sleep to clean up our brain. We're not getting into the deep stages of sleep to have our system repaired and rejuvenated. And then our body is in a constant stage of sympathetic activity, in the constant stage of stress, and our oxygen levels are down. So pretty unhealthy situation overall. And that is now correlated to a number of health consequences and very heavy conditions, which bring all the attention to that condition from both the medical and the dental field. And the sleep apnea is a very prevalent condition and is highly undiagnosed. Which is why the American Dental Association has issued a statement paper where it urges all the dentists to screen for this condition, as we are the only providers that look at the patient mouth every 6 months. And we can see certain things that can lead us to believe that maybe this patient has problem or doesn't have problem, and refer them to the proper medical doctors for more evaluation and treatment. So why does that happen? So let's look a little bit about our airway. Now, if we look from our nostrils to the lungs, the whole airway is surrounded by either some bone or cartilage, which is like a scaffolding to keep the tube patent. except for one area in the pharynx where there is no bone, there's no cartilage, it's all soft tissue. So basically that area is where the collapse occurs with the obstructive sleep apnea. And we can see that especially when we lie down, due to gravity, the tissues fall back and it's easier for this collapse to occur. Now, there are different pathophysiology mechanisms through which the sleep apnea occurs. And as I said, it's a medical condition. It's diagnosed and treated by the medical doctors. And we as dentists can contribute to the team, but only in one of the areas, because the obstructive sleep apnea could be a result of anatomy. We might have just a smaller airway, big tissues, fat tissues that just help that airway collapse. But it could be a result of disconnect in the neuromuscular control. So basically, our brain and our muscles are not working together to keep the airway patterned. Now, it could be arousal threshold issues for our brain, where in some cases, our oxygen levels go down, but the brain is not waking us up. So in this case, we stay in low oxygen levels for a longer time and create more unhealthy situation. In other situations, the brain wakes up immediately after the oxygen level goes just slightly down. And in those cases, what happens is we have a very fragmented sleep, so we're not getting the rest. So it could be also a gas exchange issue, again, a disconnect between the gas receptors and the central nervous system on how to regulate breathing. So there are even mechanisms within those mechanisms. So it's a very complicated situation. And this is why we as dentists can help in some area, but it's a very difficult medical condition that sleep physicians together with other specialists evaluate and treat. So we can contribute to the one that is due to anatomy. And what are the things that we want to achieve? Now, if we have a tube that allows the air to go through, the bigger the tube, the more chance that the air will go through and less chance that it will collapse. However, it's not the case every single time. We have patients that have bigger tube, bigger airway. However, they do collapse, they do obstruct. And as I said, this is because that condition could be multifactorial, might not be just anatomical, could be one of the other mechanisms. So that is why those appliances that we make for those patients don't work every time. But having a bigger tube is a good prerequisite for possibly healthy patterned airway. So it's a good thing to have a bigger tube. But how can we make that one? Well, it is anatomy. It's how the patient is born and developed. Also, the appliances that we make can make that tube a little bit bigger because it's bringing the mandible forward. With the mandible goes the tongue, so it opens more space behind the tongue. In terms of muscles, as we said, that airway is surrounded by muscles. So if those muscles are more toned, the chances are it can help maintain that patency during sleep. What happens is that during the day, our muscles are toned, we are awake, we breathe. Even if we have narrow airway, we find a way to breathe. But when we go to sleep, the muscles relax, and now we might lose that tone of the muscles and the collapse can occur. So toning the muscles can help. There's some evidence about myofunctional therapy, about playing some instruments that help exercise those muscles and help keep them keep the airway pattern during sleep. So that is something that is helpful. Is it 100%? Again, it depends on which phenotype the patient falls in. Tongue posture is another part of keeping that airway patterned. And we know that the proper tongue posture is on the roof of the mouth from birth. However, in some cases that didn't happen. As a result, the tongue is down, it's back, and that again creates that tube to be narrower. So training the muscles to go back to where it's supposed to be can happen through myofunctional therapy, through tongue releases, because maybe it's just that the patient has a tongue tie and the tongue cannot go as high as it has to go. Also, mandibular posture is an important part to look at. We know that for some patients with crowding of the maxillary anterior teeth, the mandibular teeth go behind and the mandible gets trapped. So now this whole complex is for the back. And again, that mandibular position is something that can contribute to a narrower airway. And this is where orthodontic therapy or restorative treatment can help, of just opening up the arch and releasing the mandible to go in the physiological position and open the airway. This is where the concept of the bigger box comes as well. Because if we have a well-developed maxilla through just development, proper development from birth, or later on through orthodontics or surgical treatment or through restorative treatment just to create wider arches, we can have bigger box, more space for the tongue, and keeping it away from the airway. Another important part is the intraluminal pressure. As I said, this part of the airway has no scaffolding to keep it open. So the reason why it stays open is because of that muscle tone and because of the pressure that is inside and outside of the walls of that tube. So if the pressure outside is higher than the pressure inside, the airway collapses. And the other way around, if the pressure inside is high, it keeps it open, which is why those CPAP machines work so well, because it blows air into the tube and keeps that pressure high in the airway and patent. So we always have to encourage our patients to use their CPAP machines, because this is something that works 100% of the time when the patient is using it and works immediately, and it's for their health benefit. However, if we have ways that we can make the complex such that can help with the CPAP machines and help the medical team and maybe have lower pressure for those machines, or potentially be able to use only appliances or just expand the arches either through orthodontics during childhood or later on through surgeries, and basically create a better environment, maybe the patient will be able to have that option, which of course they love. Now, talking about the pressure in that area of our airway, it's important to mention that any nasal obstruction or anything in the nasal cavity that would interfere with the proper flow would also cause the pressure in the pharynx to become less negative, more negative. So it creates like a suction and the pharynx collapses. So looking at the nasal cavity, working with the ENT doctors is also very important. And also through the maxillary expansion, what is interesting is that our palate is the floor of the nasal cavity. So if we are able to expand our palate, we're also expanding the nasal cavity. So now we have more volume in the nasal cavity for air to go smoothly in and create less discrepancy that would create collapse in the pharynx. So all of this is something that we can look into, we can evaluate, and make sure that we don't make worse for our patients as we do our restorative treatments. So we have evidence that maxillofacial hypoplasia is a predisposing factor for the development of obstructive sleep apnea. Transverse maxillary constriction is associated with alternation in tongue posture and high nasal airway resistance. That nasal airway resistance, I mentioned, that creates more negative pressure in the pharynx and that potential for collapse. The transverse maxillary expansion increases nasal cavity volume and decreases nasal airway resistance. Children with transverse maxillary constriction have shown OSA treatment success with rapid maxillary expansion after tonsillectomy and adenoidectomy. So basically, there's a lot of attention on the maxilla, on the size of the maxilla, on expanding the maxilla, expanding the nasal cavity, allowing more room for the tongue, encouraging more anterior development, more anterior growth of the face, so all the tissues are away from the pharynx and potentially have less chance of collapse in adulthood. So these are our objectives as restorative dentists, that we want to be looking into these points and see what we can do, how we can change things, how we can make things better for the patient. And when we're doing this, we're not trying to treat the sleep apnea, but we are just trying to help work with the medical team and create proper development of the child or our young adults, so we can have healthy adult later in life to deal with. So this patient is a 60-year-old male patient with high blood pressure and depression medication. You can see on these pictures that it's a very long face, and that gives us an idea of the growth that occurred for this patient, which was from childhood probably, that more vertical growth, the clockwork rotation of the growth complex. So he ends up as an edentulous patient with a narrow maxilla, high palatal vault. Now, we have to restore this patient. Patient is interested in implant treatment. We can see how the tongue is all squished in with the fissures. So he is definitely lacking some space in his oral cavity. Whether or not he has oral obstructive sleep apnea, at this point we don't know, so we'll have to screen the patient. We see on the medical history the depression, high blood pressure medication, which could be related to it. We see the squished tongue, the narrow maxilla, we see the high palatal vault. But again, we don't diagnose sleep apnea. We can screen and refer to the medical team if we have suspicion of it. However, patient is presenting to us for treatment. He wants implants. We have to treat. So how do we treat without making either a condition he has worse or potentially triggering a condition? Well, when we screen the patients, we have either patients that have OSA or patients that don't have OSA. Now, the ones that have OSA, they have some sort of a treatment, whether we are screening and referring and at that point is diagnosed, or it's already been diagnosed and the patient is now presenting with some sort of treatment. Either way, the options are either a CPAP machine, oral appliance surgery, nerve stimulation. So all of these different options are determined by the medical doctor. What about us? What do we do if we have a patient like that is the question I've been asking myself. And of course, first thing is we have to encourage the patient to use the CPAP machine. Especially with these big reconstructions we do, we have the patient with multiple temporary restorations. They change all the time. Even if the patient has a prescription from the medical doctor for an oral appliance, we cannot really give them the oral appliance until we have the final restorations. It will not fit. We cannot rely on and make sure it's titrated properly. So encouraging the CPAP use is important for patient health. Now, again, do not make OSA worse is my number one goal. So I am looking now at my treatments and trying to place the implants more flared position, more buccal angulation, so we can have the crowns, the future arch more wide, bigger, more forward position. Of course, within the aesthetic limits, but usually these wider, bigger arches look better on the patients who have already lost some tissue, some volume. So just keeping in mind that placing the implants on a small arch because the bone is there and restoring with a small arch of implant fixed bridge can create some difficulty for the patient in terms of smaller tongue space at that point, where if we try to create a bigger arch, more space for the tongue, we can just look at being more preventive and more AOA cautious for this patient. Now, after the restorative treatment is done, if the medical doctor gives us a prescription to make a mandibular advancement device, we can, of course, do that. And with those cases for implant treatment, that actually works well for the patient because the implants will not move. One of the main side effects of those oral appliances are that the teeth move, the bite changes. So having the benefit of a number of splinted implants and attaching prosthesis to those would minimize that effect. Of course, it depends what we have on the other jaws because that can move the teeth. But again, looking at the sleep apnea, it's a medical condition, so we have to always prioritize what is more important for the patient. We as restorative dentists are very cautious about tooth position, about occlusion, about contacts. But with these kind of patients, we have to make sure that they can breathe, they're healthy. So basically, my message is let's try to make bigger box so we don't crowd the airway and just act more preventively. Now, if the patient don't have diagnosis for obstructive sleep apnea, the same thing. We will try to make the big box. We will try not to crowd the airway, and hopefully he would never need any other treatment for his airway. Now, can we make the box bigger? That's the biggest question. Now, it starts from birth. The maxillary development is mostly stimulated from the forces of the tongue. So if we have a tongue in proper position on that palate, it's a very strong muscle and helps that palate develop, that maxilla develop. Now, in some cases, the babies have a tongue tie that is not diagnosed, so it doesn't allow for the tongue to press against the maxilla. Now, those evaluations of the tongue ties early on are very important to free up that tongue so it can go in the right position and stimulate the proper growth. The other thing is the bottles, which unfortunately is a reality for all of us working moms. We have to give the kids bottles. And the bottle, what it does is that part of the bottle sits between the tongue and the palate. So the tongue is not exerting the pressure it's supposed to for the proper development. So if these things become chronic, the kid can develop in more long face with a narrower underdeveloped maxilla, vaulted palate that would also correspond to a narrower nasal cavity. And eventually, when the teeth are lost, we see these patients with narrow arches and vaulted palates and long faces. Also, we have to remember that the bone on the maxillar resorbs in upward and inward direction, which basically means that the longer this patient is edentulous, that arch becomes smaller and smaller and narrower. So if we place the implants parallel and end up with a small arch of implant-supported fixed restoration, we might create a smaller space for the tongue. And we see these patients every day. We see the big tongue, the maxilla is resorbed quite a bit. And now even if we find a space to place implants, again, we just want to be more mindful into how we angle those implants so our restorations have a wider arch. And this is basically most we can do nowadays with today's available techniques. Now, this is what is supposed to happen from birth with breastfeeding and proper stimulation of our maxilla from the tongue, developing into a more square face, more anterior growth, more transverse growth. So we have these wider maxillas, wider palates, and more space for all the structures. And a few minutes on just brainstorming on how can we make that box bigger. Now, we can do dentoalveolar expansion, which is basically just aligning the teeth. If we have a more triangular arch, we can open it up and make more of a round arch. We can do this with either Invisalign or any clear aligners. We can do this with braces, with or without corticotomy. So this is simply orthodontic treatment. However, I want to be very clear that this is not, we don't use Invisalign to treat obstructive sleep apnea. No, we don't have that evidence. However, when the patient presents interested in aligning their teeth, our focus right now is let's not do any interproximal reduction and try to retract everything in. Let's try to widen the arch as much as the bone allows, or if it doesn't, we can do some grafting and make that arch bigger, give the patient more space. So this is the goal for this dentoalveolar expansion, to just create more space for the structures. Now, it can be done with, without myofunctional therapy. Myofunctional therapy, as I said, focuses on the position of the tongue, training the muscles, so better muscle tone, potentially less collapse. Now, in terms of different type of expansion, the rapid maxillary expansion with kids, that has actually proven to be beneficial for expanding the palate, increasing the nasal cavity volume, and decreasing the air resistance through the nasal cavity. So that is something that is very beneficial. Unfortunately, there's an age restriction to it. And once the suture, mid-palatal suture closes, it's not efficient and can cause actually tooth tipping, dehiscencies, bone loss. So it's something that is limited by the age of the patient. But again, it's the same concept of making the bigger box, but with the added benefit of expanding the palate and increasing the volume of the nasal cavity. Now, what happens with adults, though? With kids, they're growing. We have windows of opportunity to make things better for them. However, with adults, unfortunately, the options are more limited and more invasive. There are a few techniques described. One is the MARPI technique, the micro-implant assisted rapid palatal expansion. In this technique, the implants are placed around the mid-palatal suture and the appliance is activated, no incisions in terms of the bone, no surgery, just minimally invasive placement of those mini screws. And it's done under local anesthesia. Now, the other option is more surgical. It's the SARPI technique, which is the surgically assisted rapid palatal expansion. In this technique, there's no mini screws placed in the palate. It's tooth-borne expander. However, there are cuts down in the jaws. So we have a mid-palatal suture osteotomy and a Lefort 1 osteotomy. So with the MARPE technique, the expansion is, so this is the SARPI technique, and with the MARPE and SARPI, the expansion with the MARPE is more transverse, so has more benefit on the nasal cavity. With the SARPI, the expansion is more on an angle because of the cuts and no implants in the mid-palatal suture. So these are all studies and techniques performed. The studies are mostly in the 20, 30, 40-year-old dentate patients. So again, for our edentulous patients that are in more advanced stage presenting for implant placement, the options for making that box bigger are very limited or none. Now, there is a technique from the group in Stanford University, which describes the dome technique, which is a distraction, osteogenesis, maxillary expansion, where screws are placed around the mid-palatal suture, and the palate is expanded. We can see the change in the nasal cavity. So they're reporting really good data on the airway resistance and indexes which are related with sleep apnea. So it is very promising. I haven't seen, however, for completely edentulous patients, this technique. So I will have to see if I can contact the group and see how they feel about completely edentulous patients, as this is our targeted group. But really, for our edentulous patients, the options are very, very minimal in terms of expanding the palate. And it's really more of a prosthetic option where we can just restore these implants on an angle, like place the implants on an angle and have the prosthesis on an angle to provide a bigger box. There are also the Biomimetic Appliances, again, for dentated patients. The research from Dr. Singh and the Vivos group, which basically are targeted in stimulating growth centers in adults through vibration of these little wires and stimulating growth in the maxilla and the mandible, even in adults. So further studies are needed, of course. This is just all the options that I have found in the literature. And again, the deficiency of options for the edentulous patient, that is our target population for those full arch prosthesis, are very, very non-existing. So this is where our future focus, I feel, is going to be in our field, to try to figure out ways for our edentulous patients, our edentulous maxillas, to expand so we can place our implants and restore them at a bigger box, having a bigger, wider palate and a bigger nasal cavity, and more anteriorly to bring all these tissues, the tongue, away from the airway, up on the palate, and hopefully we don't crowd the airway, which is our goal, and preventively to not trigger any obstructive sleep apnea episode or future diagnosis. My conclusions are that screening for our patients is extremely important, and the proper referrals. We have to look at our big full arch restoration patients, not only when they come for those restorations, but from early on, like try to catch those future patients early on when they are kids, when they are adults. Just the earlier we find any problems that we can address through tongue ties or stimulate growth or nasal obstructions, we can help these patients to become less of an issue once they lose their teeth in regards to potential for obstructive sleep apnea. And again, the biggest word of the night, expansion, expansion, every opportunity we have. And we can use that expansion as a mean for prevention. For the edentulous patient, again, that is our biggest question right now. Potentially, we can look into doing some expansion through some of those combination surgical mini screw techniques before the teeth are completely lost. Potentially that could be an option, or placing implants and then doing more surgical expansion, utilizing those implants, both the new implants that we want to use for the restoration as well as the mini screws. And the part that we can control right away is the angulation of the implants, so we can plan them that way to allow for a more wider arch for the future restoration. And these are just a couple of examples of how we have smaller maxillary size, but then the arch is restored much wider, much bigger with attention to airway. These slides, these patients are courtesy of Dr. Mikalakis, who is our professor and chair of our department. With this, I would like to say a big thank you to everybody in our team, to all of our residents, to all of our faculty, our surgical team with Dr. Patel, our program director, Dr. Hirayama, for his continuous support and his vision, Dr. Mikalakis, our chair, and wish everybody a great night. Thank you.
Thank you so much, Doctor, for your time and expertise this evening. We did record tonight's webinar and we'll email the recording out sometime in the next week. We also would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us. We look forward to seeing you on future webinars, and thank you again, Doctor.